Good afternoon. My name is Miriam Parman with Albert Law Firm, representing victims of injuries in California, Nevada, and Arizona. I'm very excited about today's panel. It is my pleasure to introduce to you Dr. Mark Burdett with the Community Chiropractic Center, Dr. Harish Hassalkar with the Hassalkar Institute for Joint Preservation and Injury Care, and Dr. Kauser Sharif with the Vision Performance Optometric Center, who are here to provide their expertise and medical insight to how they can best help children in personal injury cases. And with that, let's get started. I have represented thousands of injured minors over my 22-year career. My practice has been limited to personal injury, and I have personally handled cases ranging from product liability, premises liability, auto, bicycle, pedestrian, really any type of accidents involving minors. Working so closely with injured children, I have noticed a huge gap between their medical needs and what realistically health insurance or parents are able and willing to pay for them. This needs and their needs inspired me to start the Miriam Parman Foundation for Injured Children, mpfic.org. We are the only nonprofit foundation that takes care of injured children. That's all we do. We create an individualized funding plan for each injured child, specific to their needs. We provide in-home nursing, medical devices, handicap accessibility, wheelchair vans, horse therapy, swim therapy, as well as legal help only on a pro bono basis. We don't charge for the legal help that we give these minors. When it comes to children, choices you make as their attorney sets them up for life. The parents and the courts look to you to guide them to make the best decisions for the injured minors. So with that being said, I'd like to talk about the statute of limitations. Obviously, much longer than the adults. And please take your time. Make sure that the minor is properly treated. There is no rush to settle a case. I'd like to give you an example. I had a recent case where a statue at a furniture store fell on top of a minor's foot. Her parents didn't do anything about it for 10 years. After 10 years, they reached out to me and we were able to settle that case for the minor for $300,000 10 years later. So please keep that in mind and don't rush to settle a minor's case without them really being properly evaluated, diagnosed, and treated. Now let's talk about the treatment that they need. Minors can't communicate their symptoms. It's really, really difficult for them. Most of them, especially at a young age, can't really communicate their feelings, their opinions, or really communicate, period. So clients and their parents look to their attorney for guidance. The most important part of this is to present the family with options for treatment so the injuries are properly diagnosed and treated. As you may know, many lien doctors will not treat minors. Neither will some insurance companies, health insurance, if they discover this is an injury caused by an accident with a third-party responsibility. With that, again, I would like to talk about another case. This case settled about 2 years ago, but it involved a minor who suffered serious brain injury in a rear-end accident. There were 4 total occupants in the vehicle. However, the minor suffered TBI, traumatic brain injury, and really at the beginning, it was really hard to show and prove. So the challenge becomes how to make sure that this minor's case is properly evaluated, treated, how it's presented to the insurance company. So this is a very case that I'd like to talk to you about being patient with minors and really working on the cases that we were able to turn a $250,000 policy into a settlement for the minor in the 8 figures. Then I would like to quickly talk about minors' compromises. As we all know, without one, settlement is not valid. Not only you need good results, but results that the court approves, and it is most beneficial to the minor. Most insurance companies don't ask for a minor's compromise if the settlement is $5,000 or under. Remember that parents cannot waive a minor's rights. So with the settlement agreement that the parents have signed, that agreement may not necessarily be valid. Also, let's talk about attorney's fees. I'd like to discuss that a little bit. Some attorneys may be shy to really handle minors' cases because of the attorney's fees. However, attorney's fees are discretionary. And if the court finds out that you've done an amazing job for this minor, you've actually earned your fees. And lastly, I'd like to talk about Medi-Cal and medical liens. For some reasons, especially when it comes to Medi-Cal, Department of Healthcare Services, attorneys would like to take a step back because the medical specials are going to be very small. Well, that's an opportunity to allow the minor to get additional treatment and get the proper treatment that Medi-Cal doesn't necessarily pay for. And remember, in all cases, the court has jurisdiction to waive Medi-Cal liens. Finally, I would like to talk about special needs trusts. If you haven't done one, it's very, very important with minors with catastrophic injuries so that their benefits are protected. With further ado, I would like to have the panel take over, and Dr. Burdett.
Thank you very much, Attorney Parman. Miriam, I appreciate all the work that you're doing and the energy that you put forth for the younger patients and the younger victims from auto accidents and other types of injuries. I'm hoping that my screen is shared. Can anybody confirm that? Because I can't see anybody. Miriam, can you see?
I can see you.
All right, so I'm going to presume everyone else can as well. And my name is Mark Burdett. I'm a chiropractor. I feel like I'm walking to the 25-step program. I'm Mark, you're a chiropractor, and I'm very proud and excited to be a chiropractor. I'm up in Poway, and I do see lots of kids. My wife and I had child number 4 and 5 after I retired from the Marine Corps, and I was attending Parker College of Chiropractic in Dallas, and I got all the prenatal and the pediatric and the infant experience twice while I was going through school, which is a completely different story, and you can buy lunch for me on that one, and I'll tell you the next time. Here's my first adjustment, and I hope that some of you are smiling because I am either the one on the top or the one on the bottom. That's how we all felt when we've got our first adjustment, and for those chiropractors, that's exactly how we felt when we gave our first adjustment. And I want you to remember the monkeys because they're going to come back and they're going to play an important part in a couple sentences a little bit later. The objective today is to try not only to entertain you, but inform you. This is not an education series. This is an information series to give you a source of resources and to give you a little bit more information than you had before, specifically targeted towards the chiropractic version for my portion and how it affects not only infants and adolescents and pregnancy. And the reason that I put up oh my is because it just looked like it fit. So force equals trauma. So you have the auto accident, you have something shaking, you have, and it could also be indirect force, but force equals trauma. And from here is where the chiropractor comes into play because trauma equals scar tissue. And the reason that you send your patients to see a chiropractor and the reason chiropractic is so effective and valid in the personal injury arena is that chiropractic reduces the formation of scar tissue. It doesn't make it go away, but it reduces the scar tissue. And those studies support that. That's one of the neatest and most beneficial aspects of chiropractic. Not because we are trying to limit or minimize the development of scar tissue, because scar tissue down the road equals to the dysfunction and possibly disease. The growth of the human body. So I'm going to go through a couple slides kind of fast. I don't know if I'm going to be able to have questions at the end, but if I'm going too fast, somebody put up a red flag because I can't see anybody. And I'm presuming that you're going to capture 80% of what I say. All right, so the growth and the development of the human body. Of course, the vast majority of it is formed and developed in vitro, carrying around with mom, and the functioning aspect is a different level. And so when things, just because we're born or they're formed in vitro, doesn't mean that they are fully functioning. The easiest thing for most of you to remember, and I don't know that all of you have had children, but if you do, someone probably talked to you about a little soft spot on top of the infant's skull, and to be very careful touching it because the cranium hasn't yet formed to cover that. So that's a pretty easy a fact for you to capture, that the body just simply hasn't been put together. So the skeletal structure is formally maturized somewhere between age 18 and 23, closer to 18 if you're a lady, closer to 21 to 23 if you're a guy. The nervous system, the spinal cord stops around age 4 or 5, and it doesn't really grow in length anymore. And the rest of it, the body grows and the spinal cord is just kind of there. But the brain continues its development for many years, and it's actually not well documented as to where they think that the brain stops its formal development. But the nervous system that it composes both the brain and the spinal cord is still certainly still performing in its development for some of your younger personal injury cases. Also, the major organs. Many of you know or might know that the digestive tract is a real easy one to capture. You wouldn't give something spicy to a small child because it rips up their intestines, and they have all sorts of sometimes projectile vomiting kind of responses. And as a parent, you don't want that. So as those major organs develop over the years, then they are more adaptive, more receptive to the other parts of the human diet. So doesn't that logic then make sense that if somebody gets ratcheted around in a car seat, or if they have a direct or an indirect force, that they are going to experience a different level or potentially experience a different level of trauma that might affect the development of the skeletal structure, the nervous system, or any of those major organs. And because of that, most of the things that are done in that first handful of evaluations of a very small patient, and this could be anything from an infant up through an adolescent, you are documenting baseline data. And so and we'll talk about in just a second, documentation. The chiropractic techniques, there are a lot of them. If there was only one technique that worked for everybody, there would only be one technique. And in fact, one technique doesn't work for everybody. You probably have heard of some of these names before. They're all listed up there in front of you. And there are more. There are probably 15 to 20 mainstream chiropractic techniques. And each one of them, in the formal setting of the universities, of the classes where we learn these things, it is very significantly focused in on the adult. And then they will have a branch of each of these techniques that says, and if you have a small child, or if you have a pregnant lady, or if you have an infant, these are the techniques that are best suited for those. And there are some seminars and some not necessarily accredited, but some very well respected organizations that train chiropractors to work very effectively, proactively, and for the adjustment of the spine, but not necessarily focused on trauma. But nearly all of these versions of these alternate methods are regarding adjustments for the adults, and everything is just a little bit different for the other younger patients. And those younger patients, they do include teenagers. Until that spine is fully matured between age 18 and 23, you have potentially other issues that need to be documented in the examination. The 80-10-10 rule has to do with chiropractic and chiropractic techniques. If the doctor is fully confident and competent in the examination and the application of the technique, 80% of the people that chiropractor cleared for that technique will see significant improvement. 10% will only see a little bit of improvement, and 10% will see no improvement. Nowhere in there does it say that anybody will be hurt. That's because the confidence and the competence of the exam will it's like a flow chart. If certain factors are found during the examination, certain techniques are taken off the opportunity to perform block. So the training, the chiropractor's training and the competency and the experience and the comfort zone with regards to significant trauma is not well covered in any chiropractic curriculum. The chiropractor's training and competency and experience is with regards to maintenance care or providing an adjustment to a smaller patient is covered in the vast majority of the schools. However, dealing with significant trauma and having the right kind of an examination and documenting that for further years, such as Miriam brought up, there's a 10-year later, they went to all the reports that were done 10 years earlier. And if someone just simply said, oh, you'll be just fine, take a couple Tylenol and march on, and they don't document their baseline data, the case that Miriam was celebrated may not have come to fruition. And unfortunately, there's not a universally accepted or recognized national or state board for certifications of children's techniques. There's not a diplomate. There is every state that provides a license for chiropractic, and certainly here in California, the licensed chiropractor has the clearance because the training comes from the school to provide some level of care, chiropractic care, to patients of all ages. All right, so more into the specific auto accident or the trauma or the mechanism of injury. And it could be someone was on a roller coaster if they're super small. Seat belts for small persons are poorly placed. They could be across a tender spot. They could be across lymph nodes. They could be across a major organ. They could be across arteries. They could be across the spine a little differently, and the impact is in the right direction. And it could be from any direction that you have trauma that no one else is going to recognize. You're not going to say, oh, then logically the mechanism of injury was the seatbelt was on a properly fitted seatbelt for a small person can still be the mechanism of injury. Car seats are great if the child is super small. The smaller the child, actually, the car seats certainly are more beneficial. However, we who are parents know that as soon as your small child is excited about being a big girl or a big boy, they're very excited about sitting in a little booster seat, and they want to get there faster or earlier than the parents maybe should put them there. But that does take place. And so for you to document or to have documented what type of car seat, what type of booster seat, what type of seat belt, and maybe take photos of how it was specifically applied during the moment of impact. Growth plates and the developmental processes, the skeletal system, the immune system. One of the fun things that, not necessarily fun, one of the fun facts about development of the brain is that the space in for the brain after the growth plates come together and the skull is formed, then you have small little spider-like webbing that takes place to try to park the brain into a position where it can function. Shaken baby syndrome is something that's coming up soon. All right, so when you have a chiropractor involved in a personal injury case, you've got soft tissue damage and you got some soft tissue injury. That's where the chiropractors, that's where we come in to help reduce that scar tissue. We're not there. We need to have the MD involved when there's a fracture or when there's a surgery or there's a surgical consult because the victim was already in an accident or maybe had surgeries in the years prior to. So the soft tissue injury is the very logical place to have a chiropractor as part of the team, not necessarily, and I strongly encourage not to have just a chiropractor, and I'm in that category for significant cases. If you have kids that are involved, to have a specialist with regards to small children and auto accidents to document a portion of the examination findings, that is a super smart, very safe, proactive approach. Unfortunately, when you have some cases, in some of the cases, not all the cases have great coverage. That might be a minor case, and you say, oh, fine, let's do the rest of your healthcare through your primary. And when they go to their primary, It is the primary medical doctor may not be well versed in documentation for the trauma of small children, and it may not get the documentation that it deserves and warrants. And so to have the quarterback of a case, or to not have the quarterback of the case be the chiropractor or the medical doctor, it really doesn't matter. It's really not the question. It's just to make sure that you have a team of professionals taking care of that young patient. Symptoms that patients and parents and doctors look for when regards to smaller children, particularly if the patient can't speak to us and we're in an examination room. So the kind of questions that we ask the parents: change in bowel or bladder habits since the trauma, change in diet or eating patterns, changing in sleeping patterns, whether or not there's colic in the super small children, whether or not it's new or increased from previous levels, or any type of poor biomechanics or eye performance. Those are the things that the parents might see. And then sometimes the parents are going to say, you know, my child just doesn't seem to be the same. And those are also wonderful things to make sure that you have documented. And if you hear any of those during your consults, you want to make sure that you get those young children evaluated by a qualified practitioner. The shaken baby syndrome. I imagine most of you have heard of this. If you don't fully understand it, it's because those spider-like things in the brain have not fully gotten a hold of the brain. The brain is loose, and the child was shaken to some amount, and it has caused a bruising of the brain as it's banged up against the inside wall of the cranium, of the skull, and a wide variety of horrible things and outcomes take place. So just short of shaken baby syndrome is a significant force that pushes with X number of pounds of pressure in some direction, and it could be from any direction. It has a tremendous opportunity to cause mild traumatic brain syndrome. And if the patient can't speak because they're less than 2 or an infant, how are you going to document that, and how are you going to justify that? Those are very difficult questions for all providers. And that is why you want to make sure that when you have a small child, that you have qualified examiners fully document their findings as baseline data, because your baseline data could be viewed and reviewed and taken to trial in future years. All right, so research, there is some research with regards to pregnancy and small children's. It's kind of limited, but it does exist. If you'd like any of these, I'll be glad to forward them to you. Adjusting during pregnancy, it benefits the reduction of pressure on the pelvic floor, which allows the baby to be carried in a more healthy manner. The side impact of this is the American Association of Automobile Medicine, the AAAM, came up that their research showed that a side impact can be just as damaging than a frontal or a rear end for children because of that of the trauma and their development, particularly an increase for children ages 0 to 4. The reason that there's not a whole lot of studies is because it's chasing data as opposed to quarantining your study group. Not very many parents are going to say, okay, fine, take my 3-year-old and put them in through trauma and have a, and do study on them and do research on them. Of course, that was kind of an awkward even thought that no parents are going to put their children into a study group like that. And so any research that takes place is, it's called observed research studies, where you can, you have to go and you have to find the research that's already been done, or take cases and try to create similar threads. They evaluated 728 pregnant personal injury victims and found out that the vast majority of them had severe adverse outcomes during pregnancy. Some of them were listed there: preterm labor, uterine rupture, and placental abruption. The belt positioning with or without booster seats, that also is a study put out by JAMA, and it's available. So I tried not to bore you. I tried not to cover into too much detail. I just, again, wanted to inform you that there's a lot to documenting, evaluation, and treatment plans, and expectations, and being part of a team when personal injury cases involve small children. And also very clearly, if a husband and wife are out and the wife is pregnant with a child, that there are 3 people in the car, not 2. So there you go. I don't know who's, Audrey, are you moderating?
Ms. Parman, I believe is
Ms.
going
Parman,
to
if you would like,
segue.
that concludes. I don't know if I'm taking questions at this point. or not.
No, actually, I apologize. My sound was off, but I'm moderating.
All righty. Well, Miriam, I am done. Thank you for the opportunity to make a contribution today. I hope it was beneficial for some out there. And I pass it back to you to pass it off to the good Dr. Holsacker.
Thank you so much.
Thank
and
you.
Thank you for joining us today. I
Thank you,
would
Mark.
like to introduce you now to Dr. Holeskar. I'm sorry. Go ahead, doctor.
Thank you, Mark, and thank you, Marianne. That was a fantastic presentation from both of you. Just a quick introduction from me. I practice here in San Diego. Those good days of actually seeing your entire audience are gone. I don't really know who's on the other side, but hello to everybody. Hopefully, I know a few of you. I did my orthopedic residency training at University of Pennsylvania, Philadelphia, and amongst my multiple fellowships, I have 2 fellowships in pediatric orthopedics. One at Children's Hospital of Philadelphia, which is arguably the best children's hospital in the United States, and the other one at Great Ormond Street Hospital for Sick Children in London, which interestingly is the oldest children's hospital in the world. So with that, I'm going to start off with my assignment, which was to discuss about pediatric injuries in personal injury. If you can take anything from this presentation, I think these 5 points are really important, and I'm going to try my best to discuss most of this. Some of these have been alluded to by Miriam, and in fact, Mark has also highlighted a bunch of this in his excellent presentation. The key is to understand the differences between small children versus adolescents versus adults. You need to understand that children have growth plates that Mark was talking about, and there's acute and long-term consequences to growth plate injuries. It's important to understand that the same delta V can cause a different injury in an infant, a different injury in a 5-year-old, a different in a 16-year-old, and a different in a 75-year-old. You need to have trained and specialized providers. I cannot agree more with Mark that you need to have people who care for children and understand children, because multiple injuries can be missed. Some of them can be psychological, neuro-ophthalmological, cognition, memory, neurospeech. And finally, if you don't understand pediatric trauma, you cannot sit and calculate damages and future care. Marian gave a great example that she settled a case 10 years later, and you have to wait sometimes to even see what the damages can be in pediatric patients. The eye sometimes does not see what the mind does not know. To begin with, children are not small adults. What happens most of the times is, you got 4 people in the car accident, and it was a T-bone. And sometimes you wonder why there's not so much injury in the 2 children sitting at the back, whereas the front 2 people got so much damage. Children are not necessarily small adults, so their presentation, their shock absorption, their biological and physiological changes are much different than adults. And adolescence is completely a different animal, I would say. It's neither apples nor oranges. You have a completely different set of people, and we'll talk about that from perspective of diagnosis as well as treatment. So if you look at the adult body height versus chest versus waist ratios, children have a different ratio. So the biomechanics of injury in children, which was nicely alluded to by Mark in terms of what sort of a seating arrangement is there in the car. Is the child in a booster seat? Is the child in a true baby seat or not? And those things matter. Are the straps appropriately placed? What was the mechanism of injury? Sometimes it's really important, like Mark said, to get a picture of the actual seating arrangement in the car with the straps that were placed on the baby to even understand the mechanics of injury in the child. And then the million-dollar question of growth plate. If you were to look at this picture, this is the end of the bone or the articular cartilage. That's the shaft of the bone or the diaphysis. And then this blue line between the end of the bone and the shaft of the bone is basically the growth plate, which slowly grows and gives length as well as shape to the bone. So growth plate injuries are really common in pediatric population and can be easily missed. I think Mark alluded to this, so I'm actually going to skip this slide, but it's very important. I mean, an entire $1 trillion industry came out of just car seating arrangements for children. So imagine how important even the industry looks at it from the perspective of mechanics and car safety. So growth plate. This is a great picture of a knee x-ray, which shows the end of the femur bone here, the tibia or the leg bone, and that's the knee joint. But look at this radiolucent line here. That's the growth plate of the leg bones. And you can imagine this one growth plate in a boy or a male child gives 1 centimeter of growth every year until skeletal maturity, which is 17 years. And in females, about 8 millimeters a year until skeletal maturity. And that's just one growth plate. Why is that important? Because look at this injury. This was a car accident, and approximately 3 years later, the child has a 6 centimeter limb length inequality. Had somebody gone ahead and settled this case or not evaluated from a pediatric perspective, you're going to completely miss this disastrous deformity that happens with time. Growth plate injuries have been classified into multiple types, and I'm not going to bore you with that, but that's more for radiologists and orthopedic clinicians and chiropractors who take care of these patients to see whether you're going to eventually deal with a longitudinal deformity, which is just short leg or long leg, versus an angular deformity. These injuries are missed because they are not seen by people who don't commonly take care of pediatric patients. For example, this may appear like a normal growth plate, but that's a separated growth plate there. And a radiologist could easily, who does not take care of pediatric patients, can easily miss this injury. What happened? This particular patient, look at that. 2 years later, you got a significant bow leg deformity and a recurvatum deformity. And that's just from a completely missed injury at the time of a car accident. This is what appears to be a simple injury to the ankle. You may want to look at it and go, that's not even a displaced fracture. But you know what? Look at this. It's gone through and through the growth plate. Okay? Fast forward 2 years later, boom, look at that. You get a deformity of the ankle with a complete varus situation, and that ankle is now a missed growth plate injury. So growth plate injuries are important. They can happen and will happen during motor vehicular collisions, during high velocity injuries, and they can easily get missed if somebody who's taking care of these patients is not aware of what growth plates are, how to examine children, and how to take care of growth plate injuries. This is a cervical spine x-ray in a 3-year-old child, and arguably two radiologists missed this injury, but the child kept being very symptomatic and crying. And you know what it ended up being? We had to get a CT scan. It was a odontoid fracture of the neck. This child required immobilization for 2 months to eventually get his neck treated. So completely missed injury. And people kept thinking the child was just throwing a fit, was maybe too anxious or frightened, having nightmares. No, there was a legitimate injury that was being missed. Clavicle fractures, this is a very typical adolescent clavicle fracture. And the reason I put it is this very typical Z-shaped fracture with a longitudinal split in the center only happens, or most likely happens, in teenagers between the age of 13 and 18 years of age. And it leads to shortening, overriding, sometimes tenting of the skin, and sometimes can poke through the skin up top through the neck. So these need to be fixed and these need to be repaired, particularly if they are poking through the skin or almost ready to break out through the neck area. And that's a teenage fracture. Yes, in teenagers, you may have to put hardware and metal to fix them. This is in a younger child where we end up putting pins. And that's the difference between younger patients and older patients. So younger patients actually are not fixed with plates and screws and rods. We actually put pins in there to hold it for a period of 3 to 4 weeks till everything heals up, and we then take the pins out. But if it's an older patient, like this 14-year-old, where the growth plates are almost shutting down, you can see that it's halfway shut down there, almost some part of it is still open. you can actually get away by putting adult type fixation in there. So this changes everything when you go down to calculating the costs of surgery, the hardware, the implants and everything, and damages can totally differ based on the age and the type of fracture, adolescent versus adults or younger children. This is a fracture in a 15-year-old boy. See, the physis growth plate is almost ready to shut down. And when it's almost ready to shut down, these patients can actually be treated like adults. And so you put a rod in there, fix it with interlocking fixation, and it goes on to full good healing. So even though the patient has growth plates, but because the patient is now almost closing down to an adulthood, you can go ahead and fix them like adults. This is an ankle fracture, and so very similar to the one I showed before, displaced that way. Once it's displaced and separated, it has to be fixed with a compression screw. Otherwise, it's going to go ahead and form the same deformity like it did in that previous patient. So these, again, are identified sometimes by practitioners, but they go, oh, it's a child. Don't worry about it. Let's put him in a boot or something and it should heal. And no, that's not the answer. These need to be anatomically fixed. Otherwise, the patient's going to go ahead and get deformities as they grow further. This is another thing that you will see many times in the MRIs and you will not know what to do with them, is pediatric patients may not actually get a fracture. They get what is called as an osteochondral defect or an osteochondral injury, which means a piece of bone with cartilage may separate at the time of the accident or injury, and that can cause an osteochondral injury. And what we do for them is biological treatment. If you do plasma injections or PRP injections, these patients respond extremely well. I think a lot of practitioners, including lawyers on both sides of the aisle, now are aware of plasma and PRP and biological treatment. But back in the day, 10 years ago, people would think it was some sort of a taboo, but they actually do work and help in the healing process. Be aware of biological modalities of treatment for pediatric population. I think this was alluded to by Mark quite extensively, including the shaken baby syndrome. But what I want to explain is that I think the next speaker is actually also going to talk about this, which is very interesting because concussions, shaken babies, traumatic brain injury in pediatric population may get missed extensively. You may just feel that this is a quiet child, a resigned child. Why is he behaving differently? And it could be a minor concussion, and they may present with vision problems. I think 68% of children experience some sort of vision problems if there's a concussion. And I think you should wait for the next talk. I don't want to elaborate too much because I think the next speaker is going to talk about this. But yes, in our practice, we get a neuro-ophthalmologist to routinely evaluate all pediatric and adult patients for vision issues when they have they're in a car accident or the impact is pretty high. Some of these vision issues may correct themselves in about 3 to 4 months, but it's still good to get a good evaluation for concussion purposes. And finally, last but not the least, I think what is overlooked in pediatric population, which I think Marianne talked about, is the psychological aspects of injury. Children tend to get anxious, depressed, resigned, they get nightmares, they freak out sitting in the car anymore. And it's a big setback for pediatric population. Some of them regress in terms of their growth and milestones when they go through car accidents. So this component is very extensively reviewed in our practice. We have 2 good clinical psychologists who thoroughly evaluate pediatric patients and go into these aspects of injuries to document them very well in pretty much all cases of personal injury, especially dog bites, as well as car accidents. I wanted to keep it short and sweet and stick to my time, but please let me know if anybody has any questions.
Any questions?
I see there's a question in the Q&A. Do you want to?
Oh, I see it. Yes. Can you see that? It says, what symptoms do you look for to help diagnose growth plate injuries? Some parents are reluctant to treat their kids.
That's a great question.
Okay, not done yet. Do you see the question? I just don't know if you can see the question.
I am not, let me see Q&A. What symptoms do you look for to
Yeah,
help diagnose?
you
Some
see,
parents are reluctant to treat their kids, don't notice or downplay their injuries. At what point should an ortho absolutely be seen for a child? Uh, Down here in San Diego, I routinely get to pretty much see almost, I would say, 95% of children who are involved in motor vehicular collisions or personal injuries for a primary evaluation. I think unless you have a very good practitioner like Mark, who's trained to do pediatric work, or somebody else who's a chiropractor who's trained to do pediatric work, a global pediatric initial comprehensive evaluation may miss injuries. It's very, very important for a practitioner to be very conversant with treating children, to know how to gain their confidence, to be able to sit with them and get a good exam. We almost take 45 minutes to examine the child from head to foot. The child is never placed on the bed. It's placed on the mom's lap or dad's lap if it's less than 5, and then comfortably examined to get a good eval. If you find areas of tenderness, you need to examine them with radiographs or ultrasound to pick the growth plate injuries earlier on, because the outcome of a growth plate injury, non-displaced, is extremely good if immobilization is given in time, which means initial 2 to 3 weeks of casting is all they may need depending on their age. If you miss that golden window and nobody casted or treated the child or splinted the child, then you have caused more damage to the growth plate than what you can think of, because the child's been pretty much walking on that despite the injury. And so that's the initial ticket, is a full comprehensive evaluation. What I often see as an expert in cases which are 2 years, 3 years down the line is child broke the femur, broke the tibia. You're almost ready for a mediation next week, and you're like, hey, Hosaka, can you please evaluate and see what can be done? And so the important thing is to note that don't wait for 3 years. Every 6 months or 1 year in these pediatric cases, have the orthopedist or the chiropractor involved reevaluate the patient, have them take measurements, make sure limb lengths are still equal, make sure there's no progressive deformity in the child that is happening. And then that documentation is so helpful to show how a growth plate injury is slowly evolving itself into either limb shortening or an angular deformity. I can't tell you how many times policy limits have been delivered once a proper documentation of limb length inequality or deformity has been conducted by somebody and objective data has been submitted to the other side. I hope that question, the answer helps your question. Anybody else?
Yes, we love some more questions from the audience, just because we are waiting for Dr. Sharif to get into the office. So just, it'd be great to do a little Q&A portion. If anyone has any other questions for our panel today, and then in a couple minutes, we'll be able to segue into Dr. Sharif's section on neurology and diagnosing children. So let's see. And we answered the question about child seats being attached to the car.
did. There was a question posed that specifically asked if a child seat should be very rigid and hard connected to the car, or should there be some wiggle room? Generally, there's some wiggle room, but the best way to have those checked, if you're a parent and you're concerned and you're not sure about how to install, if you can actually schedule an appointment with the California Highway Patrol. Not every single location provides a service, but they'll direct you to the proper one. And once you have an appointment, an actual officer can check and make sure that the child seat is installed properly and it's safe.
Excellent. And then is there any questions from you, Ms. Parman, to the panel on their presentations that you of note that you noticed? You know, there was a lot of good actually overlap and cementation of what Dr. Holsekar was saying earlier as well with Dr. Burdett that I really enjoyed.
No, absolutely. I really don't have any questions. They basically were very specific and very direct in how children should really be treated differently than adults. And getting someone who is trained and also generally treats children. It's very, very important. It's very different, just as an impact can injure somebody who's an adult differently than as a child. The treatment for the same or similar injuries are definitely different. And as experience, I have seen children recover tremendously well, which is amazing, and that's their power of healing. And then I've also seen them regress and really, really become worse off over time. So it's really important to be patient. Don't rush into anything. Really listen to the parents, listen to the children if they can talk. And a lot of times their friends will have some contribution as well, as far as saying, so-and-so is not playing the same way with kids or doesn't act the same way when she or he comes to my house. So it's really, really important to do the investigation, to really be able to know what type of injuries or as close as you can before, as an attorney, before you send them to a physician for a diagnosis. But really try to understand for the family as a whole is going through. And I think that will really guide you in being able to provide the best options for their medical treatments.
Excellent.
Any more questions from the audience?
So we're going to be getting Dr. Sharif in here. Just want to make sure if there's any last questions, this would be the time for that. And then we'll be able to conclude the presentation. Thank you all for joining us, by the way. Really appreciate that. And let's make sure she's coming in. And Dr. Hosakar, how long have you been in practice for?
I've been in practice in California for 12 years. I have been an orthopedic surgeon since 1998.
Oh my goodness.
I deceptively look young.
That's great. And you say you actually go out of state. You're part of different institutions out of state that you work with.
Yes, pre-COVID, yes. Now I have stopped. I still, once it's back to normal, we'll go back and do our mission work overseas. We go twice a year to do mission work and treat pediatric patients and adults both overseas.
Great. Well, Dr. Sharif just popped in. Thank you so much for joining us. And we'll go ahead and take the questions at the very end that just came in. And Dr. Sharif, whenever you're ready, we'll defer to you.
All right. I'm going to share my screen since I have a little PowerPoint. So bear with me just a minute.
Okay, while you pull that up, I'll go ahead and ask one question. So Kim asked, have you ever heard about a head trauma to a child stunting ultimate growth?
Are you asking me?
Yeah.
Okay. It all depends on the extent of the trauma and what's the repercussions in terms of the input to the brain, because a faulty input is going to impact a faulty outcome. So that's what I'm going to probably illustrate a little bit more, that there are different types of input to the brain, and vision being the dominant sense, we can not only assess the brain, the health of the brain and the function, but we can also influence the brain because it is such a dominant sense. So the answer to your question is absolutely yes, we can it can impact and stunt the growth, the development of the child.
Excellent. And we are so ready for you. So go ahead.
Okay, so this field has literally evolved very rapidly in the last few years, called neurooptometric rehabilitation. And basically, we are evaluating, like I said, it's not the eyeballs, we're using the input, the vision as one of the senses, but what we're actually doing is evaluating the brain function and influencing the brain function. So the reason visions has such a huge impact on development and learning kind of goes along with the question you just asked me, is because 80% of learning involves the use of vision. And I'll probably go a little more into detail. What we perceive, meaning how we understand the world, that has a lot to do with how we function. So vision definitely is the dominant sense here that can impact the function of the individual. So a lot of people have a lot of difficulty understanding um, what optometry or eyes has to do with the brain. And they always equate the eyes to glasses or eyesight. So the left picture just shows you, yes, the eyes are like a camera, that it does give us the images, but it's not static images, right? It's like a video, and it also gives us information about, the color, the depth, the form, the motion. It definitely captures and gives us that whole 3D, sense and understanding of each object or thing that we see in this world. So I wanted to get away from everyone thinking about eyes more as an eyesight issue. So I do still get referrals saying, oh, something fell into the eye. That's when they think of neurooptometry, but it's usually a lot more than that. When people have had a rear-ended, situation, the brain inside can disrupt a lot of connections in the brain that can influence that person in how that person is functioning with headaches, light sensitivity. So those are the type of people I evaluate. Yes, of course, I can take care of something fell into the eye. I mean, but that's like minimal. It's not, the TBI goes a lot further. And we need to kind of get that, mindset away from eyesight and glasses or something foreign body in the eye as the only thing we treat. Neurooptometry has to do with the brain function, like a concussion. So some of you may be familiar with this. Do you see this object here? Um, Everyone can see that it's light and, black and white, and you see some vague things there. But I'm not sure if we are having any participants able to answer what the answer is. But since I don't see any on my screen, I'm just going to go ahead and move on and show you what this is supposed to mean. This is what it's supposed to be. It's supposed to be the face of a cow. And now you can apply this to this image. And now I hope you can see what it is. Now, even though initially you may not have known what it is, you can apply that experience that you have to this image. And now I'm sure you can kind of make out what this image is. So that has to do with your visual skills in a way that you're applying the form, color, your prior knowledge, experience, and be able to identify. But a child looking at things may not even see it correctly. They may see double vision, abstract letters, and they have to correlate that to images and kind of understand what it is. It's a big step when your brain is not functioning well. This image is important because, again, everybody thinks that your eyeball is here and all that it does is shape, contrast, color. Everybody, again, thinks of only eyeglasses with eyes. But visual information is processed in all parts of the brain. The frontal lobe does the motor planning. Parietal lobe does the visual spatial map, visual attention. That's what it monitors. And the temporal lobes do object and motion perception, is is what is evaluated and given the signal to the function to be executed. And then the occipital lobe I already told you about. The midbrain area modulates the eye movements, the cerebellum especially, and then of course, the midbrain and the brainstem. This area matches the proprioceptive information from, the spinal cord and gives us, a grounded feeling. And that gives us like a foundation, which is important. Otherwise, then you're so spent in trying to just, handle that if it's not regulated well, that you're not able to process higher level cortical input. And so this is critical in a brain injury. Vestibular, auditory, and visual information here is synchronized and gives us that grounded feeling. And that's why you have so many people with vertigo, dizziness, just that not feeling, not getting that grounded feeling, and vision being the dominant sense again, is extremely important that that integration happens really well. But unfortunately, vision problems are covert and it's not even recognized as one of the things that needs to be affected. I mean, that is affected. And people are more into speech or hearing or balance problems. The motor problems are seen or diagnosed or, complained, like patients complain about it. And that's what is addressed. But no one really thinks about visual, the function of vision that really actually plays a huge part. And we call it vision sensory overload syndrome because these are all the symptoms that are there on a post-trauma vision syndrome or post-concussion syndrome checklist that you all might have. Feeling of being overwhelmed, out of step, difficulty seeing and sustaining visual attention, trouble seeing, near, of course, worse than distance. I'll tell you about that. Sometimes double vision, decreased ability to concentrate, staring behavior, poor visual, short-term memory, headaches, neck, shoulder, back pain, light sensitivity, dizziness. All those people who are, managing concussions and TBI related to car accidents, I'm sure can relate, to these types of functions from the patient. So
You first and then you.
I'm sorry. Oh, I'll go on. Okay, difficulty with multitasking, timing, lack of fluidity, is off balance, coordination, posture problems. So there's just tons and tons of, symptoms that people cannot really put their finger on, but they know that something is out of step, something is wrong. But if you don't know what is wrong, how are you going to fix it? So when we evaluate, we actually have something specific to evaluate related to their dysfunction. So we look at fixations and tracking, which are different types of tracking called pursuit, saccades, nystagmus is less common in minor concussions, but we could have something called endpoint nystagmus. And of course, strabismus is so subtle sometimes that, you'll realize it's causing a lot of problems, but it's extremely subtle. And the coordination of the eyes, light sensitivity. So anyway, not to go on and on and on with technical terms, but all those symptoms we saw in the previous page, we can actually have, objective measurements that we can correlate those symptoms to. And so it's pretty exhaustive in terms of how we have to evaluate, because now we're evaluating function. So what happens is, again, just wanted to drive home that point that people, again, only think about the Snellen chart and visual clarity, but it's actually visual perception and near vision where you have to coordinate your eyes to a fine degree that's more impacted. But so I just wanted to drive home that point that it's not visual clarity that's affected in a concussion. And just briefly mentioning, we have detailed tests. Of course, we have to look at clarity and make sure that they're seeing clear, which is a small part of what we do. Focusing, being able to switch focus from at different distances, back and forth, and timeliness and efficiency and lag. Eye tracking, we do a lot of detailed tracking, different types of tests, and there are certain normed tests. And I think Mayo Clinic did a study recently on King David tracking test for concussions. Binocular vision, of course, we definitely evaluate the input to the eye, and if on one eye is shutting down, if they're coordinated well, eye teaming, visual motor, eye-hand coordination, visual perception, visual analysis. Without the motor involvement, how are they able to analyze and get information from that? Because they match it up to what's in the brain, and then they have to make sure that they evaluate and function better. Behavioral responses to vision, if you see something like this, that means something's not right. Their eyes are not coordinating correctly, and just their overall function. They could be, posture is important, attention span, drowsiness, headaches, after work, and then writing up or downhill, irregular word, reversing letters, numbers, and all that leads to obviously reduced, understanding. And I kind of mentioned about the reversals. This is very common in a brain injury. Of course, it can happen in developmental delays, but in a brain injury, the more severe it is, we definitely see something like that too. We do have normed tests, by the way, where we can really, evaluate and the age appropriateness of where they are with the reversals also. And what do you find out? Okay, they are complaining of headaches, light sensitivity, and mental fatigue, and they don't like to read. They're just daydreaming sometimes. They substitute listening because they don't want to use their eyes, and they end up, having definitely behavior problems. So tracking, if your eyes are not really tracking well, this is like garbage in and garbage out. You're not really making words with the letters. They don't make sense. It's no wonder that comprehension goes down the tubes. So if they're not performing well, I mean, they have to do something else and they act out, and then they're called ADD or whatever, it starts affecting behavior. So the model of vision, I guess I wanted to kind of, you know, go through a little bit of a shift in how, we look at vision. Vision is represented in every part of the brain. We already went through that. Vision is an integrated brain process. I kind of mentioned a little bit. It's connected to speech, language, movement, proprioceptive centers. I kind of went through that a little bit. Now, vision directs how we move, carry ourselves, and communicate in the world. So you'll start seeing how valuable visual input is and how it has to process and synchronize with some of the primary senses in order to allow us to have a foundation and recruit higher cortical brain centers to act upon the higher executive functional tasks. So vision can work at different levels. At the primary is really important and higher level too. Vision provides the greatest economy of all the perceptual systems. Picture's worth 1,000 words. Everybody's heard of this phrase. If there was no picture and if I just had to describe this picture, it would probably take me like 3, 4, 5 pages. And I don't know if I would give you that sense of, what this all about is. I mean, looking at this picture, it's a bright sunny day and the beautiful colors and the location. You can remember it, so we want to make sure that your vision is leading. And at this point, let me also tell you that in a brain injury, the patient unfortunately does not function well to where it doesn't give us the information to be proactive, because that's what vision has to be. It has to be leading and it has to be allow us to be proactive. So you're driving on the freeway and you see a lot of red lights in front of you, you automatically take all that in, and without even thinking, you're pressing on the brakes. So you are using all your central peripheral vision in whatever sense, and you're executing an action that is allowing you to be, safe and be efficient and effective. In a brain injury, what happens is there's a lot of detours in the brain. And by the time you process each and everything, it kind of slows you down, and you will see that that patient now becomes reactive instead of being proactive. And that split difference means everything. So now they're really slow, and that builds upon itself and just makes it worse and worse and worse and worse and worse. And that's when they get that overwhelmed feeling, because before they process something, something else comes in and they're not able to be proactive. So we take things for granted when everything is working well, but you have to see this in action when things are not working well. Because I also, besides my mild TBI concussion patients, I work with stroke patients, brain trauma patients. I think I had shared with you, I go to hospitals like UCI and I see inpatients. And I work with very serious brain surgery coma patients that are just, in acute rehab. So there is it's alarming and at the same time very revealing how important and how dominant your visual input is to make you, function better. So in order to understand vision and how it develops, I'm going to backtrack just a little bit, because a lot of serious brain injury patients, they almost go back, and we have to bring them back from the beginning for certain things. So what happens is, how does a child learn? They have to touch, taste, move. I mean, they have to find out that a square peg doesn't fit on a round hole. I mean, it is by trial and error. It is by interacting with the environment and getting that feedback, and they're building this rich network in their brain based on their interaction in the world and how they understand it. Everyone is different. So we need to understand this, that everyone has a different network. And it also answers some questions about what, where, and when. This has, again, to do with certain pathways. I'm not going to go through that, but it really gives us that positional sense, spatial orientation, and a lot of different things. I can talk about an hour for primitive reflexes, but I have one slide. I cut out all the rest. The reason I have to put this in here is because in a brain injury, we have to evaluate something that we call primitive reflexes. Basically, when a child is born, until year 1, the child has some survival reflexes that are inbuilt, and it gives us a sneak peek about how patent the nervous system is, and is it functioning normally or not. So a pediatrician will evaluate this at 3 months, but within 3 months, they're supposed to have one type of reflex. And that means the child is healthy. The child has no brain damage and no development, no delays, nervous system issues. At 6 months of age, if that reflex that should disappear by 3 months is still there, that means it's a red flag. There should be a different type of reflex at that age. And these are all survival things, because a child does not know how to survive when there's input from the environment. They can't think about it. So there's inbuilt reflexes that we call primitive reflexes. So this is extremely important. And the reason I'm mentioning this is because after a brain injury, we will see some of these reflexes reappear, because now there's brain damage that has not, evolved to the degree that they're supposed to be. And attending to this, evaluating and addressing this will remove the roadblocks and will improve our ability to move forward with, the development and learning. So this is extremely important. And if they are present after a TBI, motor reflex, if it is still present, then you will see hypersensitivity, they're stimulus bound, sensory overload. They have all these issues, TLR, spinal gland, ATNR, STNR. These are all like some 5 major reflexes that we evaluate. And they all correlate with certain sensitivities and issues that this child can develop. We see this a lot in autism, for example. It's unbelievable. And so fine tracking, eye-hand coordination, posture, sensitivity, light sensitivity. There's just so many issues. Eye coordination, bilaterality. I'm not going to go through every single one of them, but I just wanted to mention that. And one of the most common things we see is strabismus, and it may not be obvious at all because it is so very subtle. There is one fourth nerve that's very long and that causes a little vertical misalignment, and that can cause dizziness and headache very badly. And it's very minor, but when you address it, it can make a world of a difference for these people. And of course, the more severe brain injury will have more obvious eye turns. And, of course, we have to, address that. And very briefly, I wanted to mention that, yes, we have to have focal vision, which is the clarity, but we also have to have ambient vision, letting us know about our positional space, and we have to have a balance. At what point do we want to, focalize? At what point we want to take in our periphery? Because what we see in the periphery gives us balance, and we need to know when to switch and adapt. Focal, ambient, they need to be in balance. And definitely in TBI, we see that most people have more focalized vision, and that's why they have balance issues a lot. They're spasmodic and they're stuck in that focalized vision. So getting them out of that mode and balancing it is a huge, help to these people. And we use something called ambient lenses. I think I'll leave it at that. I won't go too much into detail, but basically these are lenses that will help us, you know, influence the input to the brain to help reorient and improve their balance, depending on how much or what is affected. So again, prism lens evaluation, posture, attention, disposition, are they relaxed, tensed? I mean, there's so many, ways that the person is impacted, and we can kind of give them that, support. And we also do a lot of interactive, treatment by, therapy. There's something called immersion technique we call sensory learning. And then we have the usual neurovisual training to build, all the skills. This one thing I wanted to put in the slide because visual processing deficits or visual analysis skills, it definitely influence that person's ability to do any kind of work in terms like depending on how much the brain is damaged or affected, the laterality, directionality, skills are definitely in question. That they don't have eye-hand coordination. I think it's stable. Visual motor integration, of course, is going to be impacted. Visual perception, I think I kind of already, mentioned that before. Your analyzing skills, visual discrimination, visual motor, visual spatial relations, visual form constancy, visual sequential memory, figure ground, and visual closure. So we evaluate all of these skills and kind of get a baseline to pinpoint, okay, which are the areas that are affected. And believe it or not, in a developmental delay or brain injury or, serious TBI, a lot of these, skills are definitely affected. So this has nothing to do with eyesight per se again, and that's what I'm trying to kind of hopefully impart, that information or disseminate that. So in serious brain damage, we kind of have to, there's no slide about treating primitive reflexes, but one of the things, laterality, directionality, things, mental map of their body, do they know where they are in space? Do you know the rights and the lefts? And so we go through like really simple steps in order to, we have to obviously get to the level of where that child is. So we start at very basic activities. We may use lenses, prisms, in order to improve their attention and focus. So we use some visual arousal activities. We have to use the tools that they can, obviously use, the chalkboard activities for clockwise, counterclockwise, and, being able to switch back and forth, the lazy eights. I mean, again, for laterality, directionality, and to just expand their ability to, switch back and forth and be flexible, because that's really, really important. We do, again, electronic eye movement recordings. I mean, how is the eye tracking? Is one eye way off, or is it loose? Is it, are they coordinated? Are they equal? How is their fixation? How are they able to focus, clear or not? I'm sorry, this thing is just something is coming in the way here. But anyway, so we do a lot of detailed, measurements. I just wanted to share one slide that, yes, on the right side, you see the actual movement graphically, and then on the left side, it quantitates, like where they are and at what grade level, or how their eyes are functioning. So we have some detailed objective baseline, having them look at something, go back and forth, or read numbers and actually read a paragraph and answer certain questions. So we actually have a small little comprehension table. So we have to have tools. I mean, do they understand the concept of same? Are they able to create and hold a mental image? Can they manipulate a picture in their mind? So we kind of have to have tools to rebuild their brain, So hopefully this kind of gives you a better model of vision, besides glasses and an eyeball issue where something fell in the eye. So that's when, they need optometry, but they may not need neurooptometry. For neurooptometry, you're again looking at the brain. TBI, especially a concussion, has to do with the function of the brain due to the types of visual input to the brain. In terms of efficiency, like visual efficiency has to do with tracking, teaming, focusing, physical, input, and it has to do with the brain in terms of processing input, and then your execution, eye-hand, coordination and how you execute a task. So vision is an integrated brain process. It's connected to speech, language areas, movement, proprioceptive centers. Vision directs how we move, carry ourselves, and communicate in the world. So it's pretty comprehensive in how we evaluate and how we address. I kind of just touched very, very briefly on different areas. I couldn't go too much in depth due to time, but I hope I will give you a little bit of an understanding about what we do in neurooptometry. So that concludes my presentation, and I'll be happy to answer any questions if there are.
Any questions at this time?
Wow, I must have been pretty comprehensive.
Yeah, you were wonderful. Thank you so much. Well, I would like to thank everyone for attending What Makes Children So Special, the unique challenges posed by accident victims that are minors, hosted by Injury Institute and co-sponsored by the San Diego Injury Network, who represents the Injury Institute in San Diego. Thank you to our panel of doctors. And at this time, I would like to invite you to email events@injuryinstitute.com to get a copy of today's presentation material. Thank you again, everyone, and have an amazing rest of your day.
Thanks, Miriam. Goodbye.
Thank you. Bye-bye.